Okay, today we will be talking about an upper gastrointestinal disorder called dysphagia, and I am Jessica Tate. Now, I know that you are all nurses, but I wanted to start off with a review of what the gastrointestinal tract is. The gastrointestinal tract, or GI tract, is a digestive tract that the body uses to process food and break it down into a format we can use once it is absorbed. And the two principal organs of absorption are the stomach and intestines. This includes the small intestine and the large intestine, also known as the colon. Today we are going to be focusing on the upper GI tract, which consists of everything from the mouth to the stomach. So this is the mouth, the pharynx, the esophagus, and the stomach. Today we are going to focus on dysphagia, which affects primarily the esophagus. I wanted to begin by talking about why this topic is so important to me and why I'm interested in it. This is a picture of my family. It's a bit old, from 2002. This is me. I am the 6th out of 7 children, so I'm the second youngest, and most of my immediate family has experienced some problem swallowing. In fact, choking has become such a common occurrence in my family that my older sister once drove herself home from a work meeting, a 7 to 10 minute drive, in a manual transmission, so stick shift, while choking, so she could try some of our home remedies that we have come to use. And eventually we got it so she could swallow and breathe well again, using a spoonful of honey. Now, there are 3 members of my family who have experienced problems the most severe, and each of them have visited the ER because of these problems. And 2 of them, one of my parents and one of my sisters, have had their throats stretched. This is a type of surgery we'll talk more about later. But one of my parents has had it done 4 times, and my sister has had it done 2.5 times. The 0.5 is because she had it done a little partial one in the ER, but they didn't want to fully stretch it. Although my family has never been told that we have dysphagia, I decided to look into this topic further. Dysphagia is the difficulty swallowing, and there are 2 main groups of causes. These are problems affecting the muscles involved in swallowing, or physical obstructions between the mouth and stomach. Now, there are 2 types of dysphagia: oropharyngeal dysphagia and esophageal dysphagia, and these are characterized by which phase of swallowing is affected and the location of the problem. There are 4 phases of swallowing, and these are oral prep. This is where the food is being chewed and tasted, the more enjoyable part of swallowing, and the food is being prepared to be swallowed by mechanical manipulation, making it small enough. Second is oral. This is where the body prepares to swallow by moving the food towards the back and towards the esophagus. The third phase, pharyngeal, is when the epiglottis, this little flap here, moves to block the trachea, which is the air pipe or the pathway into the lungs, and the food then moves past it into the 4th phase, esophageal, where it is then moved through the esophagus into the stomach. The first type of dysphagia we're going to talk about is oropharyngeal dysphagia, or high dysphagia. This type of dysphagia affects phases 2 and 3 of swallowing and is located at the higher portion, which is why it's called high dysphagia. Individuals with this type of dysphagia have a difficulty transferring food from the mouth and pharynx to the esophagus. I have included a list of causes here, and one thing I want you to note is that several of these come with age or are more common in older individuals. We'll talk about that more. The second type of dysphagia is esophageal dysphagia or low dysphagia. This type of dysphagia affects stage 4 of swallowing, and individuals with this type of dysphagia experience an inability to move food through the esophagus, usually caused by an obstruction or a motility disorder. Right here is pictured the way food is moved through the esophagus via peristalsis as the muscles contract and relax in certain patterns to move the food through the esophagus. The most common type of motility disorder that can cause this type of dysphagia is achalasia. With this motility disorder, it is characterized by a weakening of peristalsis and an impaired relaxation of the lower esophageal sphincter pictured here. This sphincter prevents stomach acid from coming up out of the stomach into the esophagus, but in this case, as the relaxation is impaired, it prevents food from going into the stomach. The second cause I wanted to highlight is strictures, or the abnormal narrowing of the esophagus from inflammation, scarring, or a congenital abnormality. Now, my sister that I mentioned earlier was recently diagnosed with eosinophilic esophagitis. This is a chronic allergy inflammatory disease of the esophagus. Because of this inflammatory response, her esophagus begins to narrow, preventing her from swallowing. There are several other things that may cause these strictures. That is just one example. Scarring is common, and with older individuals, dysphagia is common because of scarring from the natural wear and tear from using an esophagus for many years as they are older. There are several complications related to dysphagia. These include coughing and choking on food and drink, which can block the airway and cause a difficulty breathing, or aspiration pneumonia, which is a chest infection that can develop after food particles or something that's not meant to be in the lungs is inhaled instead of being swallowed. There are also nutritional implications of this disorder. These are a restriction of food consumption, which can lead to malnutrition, weight loss, and dehydration, especially if they are unable to swallow liquids. So, how do we treat dysphagia? Most swallowing problems can be treated, but may require a multidisciplinary team that could consist of a speech therapist, surgeon, and dietitian. The treatment of this disorder will depend on the type of this dysphagia, the cause of the dysphagia, and how severe dysphagia is. For oropharyngeal dysphagia, there are 3 main treatments. These are swallowing therapy, which is overseen by a speech and language therapist, or dietary changes, which are changes to the diet that allow them to have a healthy and balanced diet. This is overseen by both the dietitian and, in some cases, the speech and language therapist, as it requires a lot of mechanical altering, and a speech therapist can help decide what will be best for the patient. And then the third option is enteral nutrition. This is a secondary route to nutrition, but is not the most common and is mostly used for severe cases where malnutrition and dehydration are a risk. So dietary changes. With dietary changes, most people will be put on a mechanically altered diet, like I mentioned somewhat before. These diets contain foods that have been mechanically or physically altered to change the texture and consistency of food and must be individualized to the patient. There is currently a national dysphagia diet, which we'll talk more about. There are 3 main levels of this diet: dysphagia pureed, dysphagia mechanically altered, and dysphagia advanced. They may also require their liquid to be thickened, depending on how severe their dysphagia is. Now, level 1, dysphagia pureed, is meant for patients who have moderate to severe dysphagia and a difficulty chewing or poor oral health. The foods in this group have been pureed well or mashed to a homogeneous state, and they are also cohesive, as you can see in this image here. Level 2, dysphagia mechanically altered, is meant for patients who have mild to moderate dysphagia and have some chewing ability. Foods in this level are moist, cohesive, and soft textured. They should be easily formed into a bolus before being swallowed. Level 3, dysphagia advanced, is meant for patients with mild dysphagia and adequate chewing ability. These foods should be moist and bite-sized when swallowed, and this can include foods with mixed textures. This is the level with the least change. Now, liquid consistencies, there are 4 main consistencies. The first is thin. This would be like water. The second is nectar-like. These are fluids that are thicker than water but can still be sipped through a straw, like buttermilk, tomato juice, some cream soups. And then the third is honey-like. These can be eaten with a spoon, but when you scoop into them, they don't leave a mark. They don't hold their shape. They have a little more flow. And the fourth and final is spoon thick. These fluids are thick enough to be eaten with a spoon, and they will hold their shape, like milk pudding and some thickened applesauce. Now, the third treatment option is enteral nutrition. This may also be an option if the individual has gone through surgery and need a temporary route of nutrition. The 2 most common types of tubes used are nasogastric tubes, which move from the nose to the stomach, pictured here. The second is percutaneous endoscopic gastrostomy tube, or a PEG tube, and this is implanted directly into the stomach. The type of tube used will depend on the length that it is predicted it will be used. If it is temporary, they will most likely lean to a nasal tube, but if it is long-term, they will lean more to one of these options. And patients who need it long-term tend to prefer the second type, as it can be hidden under clothing. Now, onto the second type of dysphagia, esophageal dysphagia. There are 3 main treatments for this. Medication, which is usually used to treat the cause. For instance, if the dysphagia is related to strictures that are caused by acid from the stomach coming up into the esophagus and creating scar tissue, like what is seen in GERD, a protein pump inhibitor may be used to decrease the amount of acid coming up, which will then decrease scarring and the stricture that causes esophageal dysphagia. The second, botulinum toxin, can sometimes be used to treat achalasia, which we mentioned before as the most common motility disorder. The effects last for only 6 months and should be done with the supervision of a doctor. The third option is surgery. There are two main surgeries. The first we'll talk about is endoscopic dilation or a throat stretch, which I mentioned earlier with my family as they have had these done. This is a minor surgery with a small risk of damage to the esophagus, which patients should be aware of before getting this surgery. It is widely used to treat dysphagia if it is caused by an obstruction or if it is due to a stricture or narrowing of the esophagus. There are two methods. Either a small balloon is used, which is pictured here, and is inserted into the esophagus with the assistance of a scope, and then placed in the stricture and slowly inflated to increase the size of the esophagus and treat that narrowing. The second is a boogie, which is a thin, flexible medical instrument pictured here. It is similar to a balloon, however, it is more of a long tube that is all inflated when used. The one I have pictured here is using a guide wire to go through. If there are multiple strictures, this method may be used as it inflates more surface area. The second is to insert a stent. This can either be a plastic or metal stent and can be temporary or permanent. After the stent is put into the esophagus, it will slowly expand the passageway, allowing food to move through. After a stent is put in, the individual with this stent will need to follow a particular diet post-operation. This diet is necessary as it prevents the stent from becoming blocked or clogged and allows the area to heal somewhat. There's a few steps and tips I want to talk about. So the first 1 to 2 days after the operation, the individual will go on an all-liquid diet. Next, they will slowly move to some soft and moist foods, either when they are cooked or raw. This could be mashed potatoes, stuff like that. And then they also need to take small bites and chew their food while as that area is still healing. Some tips. If you drink plenty of fluids during and after meals, that can help the food or bolus move through the esophagus. If the individual sits up straight while eating. So as nurses, when you are working with an individual who has undergone this surgery, make sure at mealtimes you help them sit up if they want. And then you also need to have small meals often during the day, or it is recommended to be that way, as it decreases the amount of food passing that stent in a given time. Individuals with a stent, if their eating is impaired and they aren't feeling well enough to eat solid foods or soft foods, may need to have a nutrition supplement of some kind, as their diet alone is inadequate. This could be a boost or an Ensure liquid supplement. And that is the end of my presentation. Here are my references, and I am open for questions.
Very good.
How long?